I would like to thank the International Laparoscopic Liver Society, as well as the program committee of this meeting for the opportunity to present our abstract on the America's Minimally Invasive Liver Resection Database, also known as Amiles. And I also have the honor to present this data on behalf of our co-investigators listed here. As we know, minimally invasive liver resection is well established and slowly gaining acceptance across the world. As we've gained experience in these techniques, the evidence is building to demonstrate safety as well as the oncologic equivalency of minimally invasive liver surgery. Yet more studies are needed to reinforce these points and ask more nuanced clinical questions. Single institution studies often have limited power and external validity due to the uniform decision-making and operative techniques. Multi-institutional prospective studies have the potential benefit of increased power and increased external validity to explore nuanced clinical research questions and hypotheses. The Amiles Research Group was convened in 2018 from a group of like-minded minimally invasive liver surgeons in the Americas. From this, the study design was developed around a web-based secure database. We decided that we would combine both retrospective data available already in our institutional databases as well as prospective data collection. The database opened for data entry in the Castor platform in October 2019. This database collects 129 variables that include patient demographics and preoperative lab values. It collects data relevant to liver surgery, including predisposing liver disease, portal hypertension, presence of cirrhosis and synthetic function. It also collects operative details, including the intended initial operative approach, the technique used, the number of segments resected, the concomitant use of ablation and inflow occlusion, as well as details around conversion to open procedures. This data collects both in-hospital outcomes and longer-term oncologic follow-up focused on cancer recurrence and complications. The database is constructed in an online format using the Castor platform. This is a platform that's been used by previous hepatobiliary and pancreatic databases across the world. It is secure and encrypted and accessible to the investigators only, but allows real-time entry of data using online platform, and therefore data can be entered from anywhere. Data has currently been entered with data sharing agreements established between 8 centers, 7 in the United States and 1 in Canada. We're fortunate to have McMaster University from Canada, as well as Virginia Mason, City of Hope, Texas Tech, Advent Health in Tampa, Atrium Health in Carolinas, the University of Pittsburgh, and Mayo Clinic as centers in the United States. As I mentioned, data entry began on October 2019, and to populate this abstract, we extracted all data available within the database in January 2021. At that time, there were 1,261 cases with complete data entry and 30-day outcomes. As mentioned, these were from 8 institutions, 7 in the United States and 1 in Canada. The median number of cases per institution was 110, with a range of cases from 1 to 306. When we looked at our cases present in the database by procedure type, not surprisingly, we see preponderance of minor anatomic liver resections of less than three segments. This includes 899 cases. We have 182 wedge resections, non-anatomic resections, and atypical liver resections. And the database currently has 180 major liver resections of 4 segments or larger. When we look at the primary diagnosis for these procedures of the cases currently in the database, we notice, not surprisingly for a North American database, the most common indication is colorectal liver metastasis with 404 cases. The second most common indication was hepatocellular carcinoma with 386 cases. And we have 70 cases of cholangiocarcinoma and gallbladder cancer in the database. The second most common listed indication was other, that includes neuroendocrine liver metastasis, hepatic adenomas, cystic neoplasms, and other benign lesions of the liver. In terms of the initial operative approach, we can see there's a predominance of pure laparoscopic cases with 755 cases. although we show robust data entry for robotic cases at 213, as well as a decent number of hand assist cases at 238. You can see that the initial approach varies a little bit by center, and that obviously reflects the experience and preferences of the individual institutions. We can see centers with a predominant pure laparoscopic approach, as well as centers with a significant robotic case experience, as well as centers with more common use of hand assist approaches. We feel this heterogeneity approach adds to the richness of the database and allows us to ask significant questions regarding intraoperative, perioperative, and long-term outcomes comparing various techniques. In terms of descriptive statistics, not surprisingly, the median lesion number in the series is 1, with a range of 1 to 39 lesions. We have a modest median lesion size of 4.4 centimeters with a range of 1 to 85 millimeters. You can see that intraoperative ultrasound is used and documented in 64% of our cases, and that inflow occlusion using a Pringle maneuver was documented in approximately 13% of cases. Prior liver surgery is documented in 60% of cases, that 60 cases, therefore repeat liver resection experience is growing amongst our investigators. We can see that the vast majority of cases of repeat liver resection are attempted after a prior minimally invasive liver resection, either performed laparoscopically or robotically. But we also see 19% of cases being a second operation being performed laparoscopically after open liver surgery. 14.5% of our cases have the concomitant use of ablation with resection, and this is evenly distributed between the use of microwave and radiofrequency ablation. Our investigators were interested in conversion, and the conversion rate in our series is approximately 10%. We feel that this represents a real-world value, and therefore we feel there's hopefully little bias, if any, around data entry. The vast majority of these cases were converted from either a laparoscopic or robotic approach to an open approach, while a third of cases were converted from a pure laparoscopic to a hand assist approach. The most common reason for conversion was inadequate visualization of the operative field, while other common indications included bleeding and failure to progress through the procedure. I want to thank you for the opportunity to present this data that describes the Amiles database. As you can see, this is a large multi-institutional collaboration that combines both prospective and retrospective data. This represents the largest data set of minimally invasive liver surgery in the Americas. We've designed this database to be compatible with the Italian, British, and Japanese databases with similar variables and variable definitions. And we hope that this will facilitate global collaboration and cross-continental comparisons. Our data focuses on the technical aspects of liver surgery, safety, perioperative outcomes, as well as oncologic outcomes, and further investigations on these specific factors will be forthcoming. This is an evolving database, and we certainly welcome interest from additional sites they may wish to join, and additional collaborations are certainly welcome. Again, it's been my honor to present this data on behalf of our co-investigators, and again, I thank the ILLS for the opportunity to present this work.